Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on PrEP considerations in cisgender women, featuring Latesha Elopre, Associate Professor in the Division of Infectious Diseases and Assistant Dean of Diversity and Inclusion for General Medical Education at the University of Alabama at Birmingham in Birmingham, Alabama, and Karine Lacombe, Professor at Sorbonne University and Head of the Infectious Diseases Department at St. Antoine Hospital in Paris, France. They'll discuss key considerations for the use of PrEP in cisgender women, and following their dialogue, they'll field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Elopre and Lacombe.
Hi, it's so nice to be here, especially talking about PrEP with the recent updates that we've seen in guidelines and recommendations. So first, just to provide some context as to why we're having these talks. Right now, when looking at the United States, we know that there are huge gaps in who we think may benefit from being on PrEP based off of epidemiology and who is accessing PrEP. And really to effectively end the HIV epidemic, both within the United States and internationally, really a huge emphasis needs to be focused on how can we close health inequities. So specifically in America, we know that about 1.2 million people have an indication for PrEP, and it's predicted that that's 1 in 4 sexually active men who have sex with men. So over 800,000, 1 in 5 people who inject drugs, and 1 in 200 heterosexual adults. But based off of 2018 data that looked at pharmaceutical data across the board, they really saw that only 18% of individuals with an indication for PrEP in the United States are currently receiving PrEP. And we're seeing gaps in who's actually receiving PrEP among those 18%. So if you're actually looking at, again, this pharmaceutical data, trying to understand which populations are currently receiving prescriptions for PrEP, right now is primarily among white men. And this chart is broken up, which I appreciate, not only by self-identified gender, but also by race. So you can see white compared to Black, Hispanic, Asian, and then unspecified. And what you can see, which pertains to our study today, is that number one, there are huge gaps in regards to race. So we know that prescription rates are approximately 6 times higher for white individuals compared to Black individuals. And this is despite the fact that the latter group makes up about 40% of individuals who have an indication. And just looking at HIV epidemiology, they're the group most likely to be infected and diagnosed with HIV. Then if we're looking at it based off of this self-identified gender, we know there's a huge gap, especially among cisgender women. So they are least likely to receive a prescription for PrEP. And it's predicted about 7% overall PrEP prescriptions were written for cisgender women. And then even among cisgender women, we're seeing huge discrepancies in regards to race and indication. So there have been several studies, not as broad when it comes to the sample size, but showing that a lot of cisgender women who are on PrEP are in serodiscordant relationships, and their partners are living with HIV, but they're virally suppressed, meaning that they cannot transmit the virus. So recently, we had updated guidelines from the Centers for Disease Control and Prevention. And I think a lot of people are really excited about this one huge factor in the guidelines, which is that all sexually active adults and adolescents should be informed about PrEP, period. So if you have a patient who's sexually active who you're seeing in clinic, you should at least educate them about PrEP. And then it gives you this nice flow chart that talks about risk of exposure. So whether you're having an anal versus vaginal sex in the past 6 months, and then takes you down the tree as to whether you should strongly recommend PrEP for this patient. So specifically, number one, you have to take a sexual history. And I typically ask the gender of individuals who they're having sex with and the health of those relationships. But as you go down the tree, if you're having sex with someone who's HIV diagnosed or living with HIV, and they have an undetectable viral load, you see, yes, if they actually have a viral load, you should prescribe PrEP, but no, discuss PrEP and leave it up to the patient. For someone who reports more than one sex partner of unknown HIV status who uses condoms inconsistently, then yes, you should definitely have this conversation around PrEP. And still, you'll see discuss PrEP, prescribe if requested. So this is something that has also changed. This lighter green box discuss PrEP and prescribe if requested. So if someone requests PrEP, it should be written. And then anyone who's had a bacterial STI in the past 6 months, you'll see for cisgender women, this is really gonorrhea and syphilis, as well as for transgender men. Yes, prescribe PrEP. So in this next slide, what you'll see is PrEP should be used in adults at high risk of acquiring HIV infection when condoms are not used consistently. And this is from the European AIDS Clinical Society, kind of like our equivalent in regards to Centers for Disease Control and Prevention. And they recommend HIV negative heterosexual women and men. You should consider PrEP for those who report inconsistent condom use and multiple sex partners, where some or whom you do not know if they have HIV. And then the next set of guidelines is from WHO. And WHO, again, recommends oral PrEP. This is TDF-based PrEP if someone's deemed to be at substantial risk. And they base this really based off epidemiologic data. So you knowing what is the risk of someone being diagnosed with HIV within your locale. Over all of this as an umbrella term, I would recommend that really, especially for cisgender women, that you take into account the ability to discuss condom use with your patients. People who have reported intimate partner violence are at higher risk, we know, for being diagnosed with HIV. And these things aren't always taken into consideration in the guidelines. So really having a good relationship with your patients is necessary. So what are the regimens that we currently have in regards to PrEP? Unfortunately, for cisgender women and trans men, is somewhat limited. So we have TDF FTC, which is the first PrEP regimen that was approved by the FDA and has EMA approval. And it's really available for anyone with a creatinine clearance greater than 60, for men who have sex with men, heterosexual women and men, and people who inject drugs. One of our newer regimens, FTC TAF, is really only available if you're reporting anal exposure as your risk. And this is because we know that vaginal exposure was not included in the Discover trial. And then we have cabotegravir, which is one of our new regimens, which we did have broad representation in these trials. And you'll see later when Karine talks about how you can prescribe this and what they're recommending right now in regards to this newer medication. For anyone that's going to start PrEP, you should have a documented negative HIV test before prescribing PrEP. You should always review acute signs and symptoms of HIV and make sure they're not on any medications that could react with their PrEP medication. And always document HPV status, because as many of you are aware, most of our PrEP regimens will treat hepatitis B. So in our next slide, you can see that there have been tons of studies that have gone into effect that have been used to prove that TDF-FTC is effective and safe in regards to cisgender women. And the trials that we really focus on, Partners PrEP, TDF2, FEM-PrEP, and VOICE. Initially, people were somewhat, disappointed in the results, specifically VOICE, which was a huge trial that we were all very excited about, where you can see efficacy of 29%. When you look at Partners PrEP, results efficacy were 66% in women versus 84% in men. And then same thing with some of the other trials where you're seeing lower efficacy, unfortunately, among cisgender women. And the question was why? And again, as many of you are aware, when they did sub-analysis, really looking at how much drug is in our participants who were in this study, efficacy shot up much higher when you had people who were more adherent. And so a lot of work is focused on how we can improve adherence and then look at open label trials, which sometimes can give us a better shot how people are doing with PrEP, knowing that efficacy is strongly linked and correlated with how often you're taking the pill. So selection of oral PrEP regimens for cisgender women. Really, we have FTC TDF, which is recommended for all adults and adolescents. We do not recommend on-demand PrEP. And unfortunately, like I said earlier, FTC TAF does not include vaginal exposure because they were not included in the trial. There are currently some randomized controlled trials looking at the efficacy and FTC TAF among cisgender women. So we'll be excited. And hopefully this will be another option in regards to PrEP. So why is adherence so important when you're discussing TDF FTC, which is the only oral option we have available for cisgender women? It's because we have variable efficacy and really needs for high levels of adherence, at least 6 pills out of the week, because of several factors in regards to the female genital tract. And that's the lower female genital tract, the cervix, and the upper female genital tract. And this slide is really just showing you that. Some potential modifiers in regards to efficacy and really high concentrations of the drug at the tissue site, which is what you need to prevent HIV infections, are things like having efflux transporters being present, sometimes having endogenous proteins that can compete with your TDF-FTC, and then also things like having sexually transmitted infections that can change your microbiome and affect efficacy. So what this study is really showing you is that overall, when you're looking at single dose, and this is a single dose phase 1 study, comparing FTC TDF in women, when you drop the dosing to twice a week for FTC TDF, you only had 65% of women attaining target exposure levels that would actually prevent HIV infection if they were exposed. So this study, I think, is one of the hallmark studies showing you that for women, it is extremely dose dependent in regards to getting high enough concentrations to be effective at preventing infection. There is some in vitro data looking at what the concentrations could potentially look like in regards to TAF FTC. And the reason why people are so interested in TAF FTC is because we know from earlier trials that TAF is highly potent. So this slide is really just showing us that for tenofovir diphosphate, which is really what is effective, which is what the drug that is preventing HIV infection from occurring, you actually get 4 to 7-fold higher concentrations in your peripheral blood mononuclear cells with TAF compared to TDF. So hugely effective. And I think this is also one of the reasons why, even though TAF is lower dose, we don't have as many side effects with TAF. While we don't have in vivo data, we don't have randomized control trial data yet on the efficacy of TAF FTC in women, we do have some in vitro data looking at whether TAF FTC could still be an effective PrEP modality for women. And what we found is that typically when you're looking at tenofovir diphosphate concentrations, which is really what we care about in regards to stopping HIV transmission, there is no difference between FTC TAF versus FTC TDF. And so ultimately, I think most people think that this is going to be a safe option in regards to therapeutics, but we need more data to show that for sure. So we're going to switch now and talk about some of the newer antiretroviral regimens that we have for cisgender women. And I'm going to hand it over to Karine.
Okay, thank you, Latesha. So definitely we're going to talk now about the other options aside from tenofovir and emtricitabine as PrEP options, especially for cisgender women. And you can see here on this slide the dapivirine vaginal ring, which is very, very close to be released on the market. So it's a female-controlled method for HIV prevention with the delivery of dapivirine over 1 month. That's why it's a very interesting option, especially for adherence. You see that on that slide that it's an intravaginal silicone ring, which has been developed by International Partnership for Microbicides. That's the first topical HIV prevention methods that has been submitted for regulatory approval in the States, which is also under review in sub-Saharan Africa, where there is a huge need for PrEP in cisgender women. So in March 2021, the WHO has released clinical recommendations on HIV prevention, and that included the guidance on the dapivirine ring. And that was a great progress for access to PrEP in cisgender women. And in December 2021, there was the withdrawal NDA submitted to FDA by Partnership for Microbicides. So multiple studies have demonstrated HIV prevention efficacy, safety, and acceptability of this dapivirine vaginal ring. You see here the phase 3 MTN-020 Aspire and the ring study, where the HIV incidence has been reduced by about 30% versus placebo in African women. With the Aspire, we saw a 27% reduction. So that was significant compared to a placebo. And in the ring study, a 31% reduction, which was also significant compared to the dapivirine. So the dapivirine ring has been evaluated in almost 5,000 women aged 18 to 45 years old in Malawi, South Africa, Uganda, and Zimbabwe. And for in so many women, there was no concern about safety with long-term use based on an open label phase 3 extension. And more than 40 studies have been performed on safety with different dapivirine formulation, ring, of course, but also film, gel, and oral. And nearly all women found the ring to be acceptable and expressed an interest in using if it was proven to be effective, which was quite a good news for the acceptability and the upscaling, the rolling and access to that kind of PrEP method. If we look with a better focus on the DREAM and HOPE, so the RING study and ASPIRE open-label extension trials, we saw with the DREAM that enrolled previous RING study participants who remained HIV negative and did not discontinue treatment for adverse events or safety concern. There was about 941 women, cisgender women, and the HOPE enrolled previous ASPIRE participants who remain HIV negative, so almost 1,500 participants. And you see here the number of seroconversion on the dapivirine vaginal ring, 18 in the DREAM participants and 35 in the HOPE participants with the seroconversion rate. There was no treatment-related serious adverse events, and it was observed a lower monthly mean residual drug amounts in rings collected in DREAM versus the RING study. So that proved there was a better adherence in open label extension. And on top of that, the HIV incidence with the ring use in DREAM showed a 60% decrease. It was lower than simulated placebo rate. The mean dapivirine amount released from rings by end of the month was higher in HOPE versus ASPIRE trial. So that's demonstrated an improved adherence on the open label extension again. If we switch to another option for PrEP in cisgender women, that's cabotegravir, and especially this trial called HPTN 084, which was a multi-center randomized double-blind phase 2b/3 trial in participants without HIV. So you see that we had two arms, one with cabotegravir, 30 milligrams QD plus placebo, and the control was tenofovir and FTC, tenofovir disoproxil and FTC. So that was up for the first step. And then the second step was cabotegravir long-acting intramuscular plus placebo versus the regular control arm. And then step 3, everybody was switched to TDF FTC QD. The primary endpoint was the incident HIV infections, and the secondary endpoint were the incident HIV infection during follow-up and safety. So what did we observe? First, the primary endpoint, which was the HIV incidence. You see that in the cabotegravir arm, we had 4 HIV infections and 36 with TDF FTC. So you see a big difference between the cabotegravir and FTC arm regarding HIV incidence. And we observed the 89% lower risk of HIV infection for women in the cabotegravir group compared to TDF FTC. It was highly significant. We saw 4 incident HIV infections in the cabotegravir arm. 2 were observed despite the cabotegravir injection. So there was not a problem of adherence, but there was a problem of adherence with 2 of those women because we saw an absence of cabotegravir exposure. Regarding the adherence and the impact of adherence on the efficacy of cabotegravir, you see that in the subset of women who had this adherence evaluation, there was a detectable tenofovir associated with the daily use. And most of the women, 62% of the women had a detectable tenofovir concentration with the daily use of 46 or 46% over 40 nanogram per milliliter. If you look at the cabotegravir injection coverage, we saw that, in fact, the coverage was really high, even at the end of the study. That was really the difference between the cabotegravir arm and the tenofovir arm, a lot better adherence with cabotegravir than with tenofovir. So that might explain the higher number of HIV infections, the higher HIV incidence in the tenofovir arm compared to cabotegravir arm. If we go further in looking at the incident HIV infections with the cabotegravir, you see in that slide the number of infection at baseline and then the number of infection in the absence of cabotegravir long-acting. If we look at the mutations we saw in patients failing, in individuals failing treatment, We saw no major in-stil mutations in cabotegravir arm, and the HIV detection via routine diagnosing assays were delayed in patients receiving cabotegravir long-acting. That's why HIV RNA testing as primary HIV screen was planned to be evaluated in open label extension. And that's why one of the very important things to remember when we're going to put patients on cabotegravir long-acting is that we should be using HIV RNA to detect new HIV infections instead of regular HIV serology. If we switch now to the side effects associated with the use of cabotegravir, at the injection site, some reactions were seen. You see 32% with cabotegravir. Well, it was an intramuscular formulation compared to 9% with FTC TDF. And there were very few grades above 2 as injection site reactions with cabotegravir, 7% compared to 1% with FTC TDF. But above all, no discontinuations due to injection site reactions. In regards to weight change, which is a major challenge with INSTI, we saw that there was an initial weight gain increase within the cabotegravir arm plus 0.42 kilos. But overall, there was a similar median weight change between the intervention group over time, comparing cabotegravir to FTC TDF. And you see there was no difference, plus 2.2 or 2.4 kilos over follow-up over time, and no difference between the two arms. So we were quite reassured regarding weight change and weight gain in women taking cabotegravir as a PrEP treatment. Regarding now a very important outcome when we talk about women on PrEP or the pregnancy outcomes. And in this study, in the HPTN 084, we had 40 confirmed pregnancies. And the total incidence rate of pregnancy was 1.3, 1.5 in cabotegravir, and 1.1 in TDF FTC arm. So 29 pregnancies with cabotegravir and 21 pregnancies with TDF FTC. If we look at the pregnancy outcome, live births in 10 over 14 in cabotegravir, 10 over 13 in TDF FTC, and there was no difference in the rate of congenital abnormalities in both arms. And they were really, really small. Number was really small, fortunately. Regarding now the pregnancy outcomes in pregnant women exposed to cabotegravir plus rilpivirine for treatment. So that's the woman exposed to more than one dose of cabotegravir and rilpivirine and who became pregnant during the clinical trials. Per clinical trial protocol, the cabotegravir and rilpivirine was discontinued and women were switched to an alternative ART regimen. So all those women were infected with HIV. So it gives us a broader spectrum of pregnancy outcomes in women exposed to cabotegravir. So larger than only women on PrEP. And we see with this study, which reported 26 pregnancies in women on cabotegravir and rilpivirine, 11 live births, 8 elective abortions, 7 spontaneous abortion, and no stillbirths. So after discontinuing long-acting cabotegravir and rilpivirine, the concentration of those drugs were sampled for 52 weeks after the last dose, and the plasma concentration of both drugs were comparable to range of concentration seen in non-pregnant women. So that's very important to know when considering this treatment for PrEP. So when we talk about cabotegravir as long-acting PrEP treatment, a lot of implementation considerations have to be taken into account in order to facilitate uptake and use of that kind of PrEP treatment for HIV prevention. And a lot of options have been evaluated and conceived, like shot clinics in and out in clinical programs, pharmacies that could administer the shots, and the constant supply of oral formulation at home for bridges in case the shot is delayed and the dose might be missed, which is which could be very deleterious for adherence. And as Latesha told you, the adherence challenge is very, very important to be addressed during a PrEP delivery, especially with cabotegravir. Incentives could be used, mobile vans, etc., etc. And for example, in this study called Customize, which is a phase 3 implementation effectiveness study of monthly cabotegravir, long-acting rilpivirine for ART, not for PrEP, but for ART delivery, some key strategies were identified. So successful clinic implementation were due to good staff communications, teamwork, and use of the web-based treatment planner. And the patient's adherence could be enhanced with a good communication about the dosing window, effective appointment, reminder systems, and designated staff for appointment tracking. So all that kind of tools that could help to enhance adherence to PrEP and facilitate uptake should be implemented locally. So in summary, what are the PrEP eligibility criteria by regimen? If we look at the risk group, heterosexual women and transgender men, daily FTC TDF is if FDA approved with guidelines, including that association FTC TDF, oral daily FTC TDF. On demand in women, it's off-label and absolutely not recommended because women should be left on the constant dosing of treatment to be covered for PrEP. Daily FTC TAF, it's not recommended yet. Studies are underway. And if we look at the dapivirine ring, it's not available widely right now. It's WHO recommended and it needs to be implemented. So it's going to be the next step. And regarding injectable cabotegravir, it's FDA approved. It's not approved in Europe right now, but it's on its way. So it will be approved very shortly. And it's already recommended in the US, except in pregnancy. It's not in Europe, but it will in a very short time. Regarding now PrEP in pregnancy and breastfeeding, it's always a very important issue to address when we think about PrEP in cisgender women. We all know that pregnancy is associated with an increased risk of HIV acquisition. FTC TDF can be widely used, is widely used in persons with HIV, including pregnant women. There is no link with teratogenicity in the antiretroviral pregnancy registry. And we've got data from lactation studies in women with HIV suggesting that there is a very limited drug exposure to the infant. That's why FTC TDF daily is absolutely recommended for PrEP in pregnancy because of very high risk of HIV acquisition in a woman exposed to HIV on a daily basis. Systematic review of completed and ongoing PrEP safety studies in pregnant and breastfeeding women without HIV has been performed. 5 completed studies found TDF-based PrEP exposure was not associated with differences in pregnancy and perinatal outcomes. So we can be quite reassured with the safety of that regimen in PrEP cisgender women. And the analysis of the pregnancy outcomes in women with HIV on TDF-based ART and pregnant women without HIV on TDF-based PrEP has shown that there is no association with an increased risk of intraviable pregnancy and infant growth outcomes. So here again, it's very reassuring for the use of such a regimen in PrEP. Okay, so the clinical approach to initiating PrEP in cisgender women, very important to get a HIV negative test within 1 week of initiation, no signs or symptoms of acute HIV infection in the preceding month or on day of evaluation, and you can even help yourself with the HIV RNA test if you have some doubts about primary infection. The renal function requirements, if you use FTC TDF, the creatinine clearance should be above 60 milliliter per minute. If you use in the near future FTC TAF, creatinine clearance should be over 30 milliliter per minute. Documented HBV infection and vaccination status, and you should offer vaccination if your patient is not HPV immune. And you should perform HCV test as well and link to HCV clinic if there is chronic HCV infection. And you should also screen for STIs and offer HIV or HPV vaccination according to the result. You've got here the clinical monitoring during oral PrEP. And again, I would like to emphasize the importance of performing HIV RNA if you have any doubt about a primary infection. And probably in the near future, and especially with cabotegravir, this year, the HIV test that you have to perform every 3 months might be replaced with HIV RNA. STI testing, very important, HPV, HCV, renal function, lipid monitoring, only if you use TAF. So in women, in cisgender women in the near future, but not right now. The counseling of adherence and assessment of interest in continuing PrEP are absolutely paramount during follow-up. With injectable CAB, HIV RNA, as I told you, every 2 months, and then every 6 months. And then STI screening, very important, and counsel and assessment of interest in continuing PrEP again. I would like to emphasize that sentence here, that creatinine clearance, HBV serology, lipid panels, and liver functions are not indicated prior to starting cabotegravir injections or for monitoring drug use. The HIV testing recommendations, I will not spend too much time on that because we have already told you that the HIV RNA testing is recommended as routine screening HIV infection during cabotegravir use, oral or long-acting. How we can start and stop PrEP. You see here for starting PrEP, it's based on PK studies on FTC, TDF, 7 days to get an optimal rectal exposure, 7 days for blood exposure, and 20 days for cervical vaginal tissue. We, at the moment, haven't sufficient data on time to protection for FTC TAF, the same for cabotegravir. Regarding now, when we stop PrEP, the protection against HIV with oral PrEP wanes after 7 to 10 days. So there should be a close monitoring for hepatitis B. Injectable PrEP, it's a bit different. The median time to undetectable cabotegravir plasma levels is quite long, 48 to 67 weeks in study. It's kind of variable, but the concentration persists beyond protection, and the follow-up should be continued quarterly for 12 months. And after the last cabotegravir injection, if the patient wants to switch to an oral regimen, it can be done after 8 weeks. Counseling on adherence, as I told you, is a very, very important issue. There is a need to adhere to a daily pill or every 2 month injections, and almost all the failure of PrEP treatment has been associated with the bad adherence. So very, very important to enhance adherence and help the patients to take their pill or injections very regularly. And the HIV testing and monitoring by the patient should be done also very regularly. So adherence to treatment, adherence to follow-up. And really, it's very important to emphasize the need to use tools for adherence support, like reminder caps, pill boxes, refill reminder calls, scheduling follow-up visit, etc., etc. Okay, so we're going to close this presentation before we enter the Q&A session by a few take-home points. So the 2021 CDC guidelines recommend discussing PrEP with all sexually active adults and adolescents, and not only the ones you perceive at risk, or because that's very important to try to touch everybody with PrEP. Oral FTC TDF daily or injectable CAB every 2 months are recommended for PrEP in cisgender women. On-demand dosing is not recommended for cisgender women because of a lower concentration in the female genital tract. And FTC TAF is not yet recommended in cisgender women for PrEP, but studies are ongoing. FTC TDF daily can be used for PrEP during pregnancy. HIV testing with HIV RNA is recommended to avoid delays in diagnosis, and adherence to PrEP is imperative for efficacy Thank you for your attention. And I think that we can go to the Q&A session now.
All right. Thank you to Drs. Elopre and Lacombe for that excellent presentation. We've had a number of questions, and we'll do our best to get to as many as we can. The first one is, are there any specific guidelines or recommendations for women who use drugs or women who are sexual partners of people who inject drugs?
Yes, well, the guidelines are exactly the same if the risk is sexual or by drug use, and the same, the counseling for adherence, et cetera. So it's about the same, definitely.
Okay. The next question from Jerica, would you please explain why the NDA for dapivirine was withdrawn for FDA review and approval?
It was released where they got preliminary feedback saying that it likely was not going to be approved. And I believe that's why they withdrew. I know a lot of advocates are very disappointed with that because this is a mechanism I think that could be potentially empowering for a lot of women, but this is kind of where we are right now. So we'll just have to see what we can do moving forward.
Okay. Jonathan asks, what do you know about CAB administration in the context of family planning clinics where dapivirine is being administered? Is that a highly acceptable setting for CAB to be delivered for PrEP?
I can speak domestically within the United States that family planning clinics have been considered really, I think, prime implementation sites for PrEP, for oral PrEP options, so TDF, FTC. So I would not be surprised at looking at them for cabotegravir. I think it's just important to remember that if a woman becomes pregnant, cisgender woman becomes pregnant, we do not recommend that they continue on with cabotegravir because it's not currently FDA approved for pregnant women. So I think that would just be the main focus. But from a safety net standpoint, I think a reach standpoint, family planning clinics have been looked at extensively as implementation sites for PrEP.
Okay. And from Mark, any thoughts on the impact of the new HIV RNA testing guidance for sites that are not billing for services or for patients lacking insurance? And I think this is probably a good one that you could comment on the differences between the US and Europe as well.
We were talking about this before. So, Karine, you have a wonderful system. So you're saying that you guys already do this, right?
Yeah, well, in most places in Europe, and I can particularly talk about France, there is no challenge around the cost because the cost of PrEP is covered by the government, so by the social insurance. So even if you don't have a social insurance, there is a special way to get the treatment if you are in need of treatment. So it's included. So it's not an issue at all.
And, in my state, so I'm in Alabama, which we have not expanded Medicaid. We have a high number of people who are underinsured or uninsured. We have struggled with whether and how we're going to do RNA testing, mostly because we're concerned about the ability to get reimbursed for RNA tests. So I think right now we're trying to just see what's going to happen when we put it in through insurers and then counsel our patients accordingly.
And then Lauren asks, is there a timeline that you know of for TAF study completion in women?
I don't know about that. Maybe you have the answer, Latesha?
I actually don't know what the timeline is for TAF in women. So I can look that up before our next talk and try to provide that information.
Thank you to Drs. Elopre and Lacombe, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.